Hi, I'm Erin Kolmetz, President of the Pediatric Nurse Interest Group. You are watching the 6th video in our Hot Topics series, and for this video, we're focusing on sickle cell disease for World Sickle Cell Day on June 19th and Ontario's inaugural Sickle Cell Awareness Day. For this video, we're featuring Jennifer Wolfenden, a registered nurse at McMaster Children's Hospital. Please enjoy.
Hi, everybody. We're going to spend the next few minutes talking about sickle cell disease. My name is Jennifer, and I'm a nurse at McMaster Children's Hospital. What is sickle cell disease? Sickle cell disease is an inherited disease. You get it when you're born. In order to get sickle cell, you have to have each of your parents have to have the affected gene. And as you can see by the diagram, and if you remember back to high school biology, you can see that if each parent is affected with the sickle cell gene, one in four pregnancies will result in a child inheriting the copy of the faulty gene that causes sickle cell disease. 50% of all pregnancies children will inherit the trait, and 1 in 4 will inherit the normal copy of the hemoglobin gene. What are sickle cells? This is a great diagram showing what sickle cell hemoglobin, red cells, look like in your blood vessels. You can see that the cross-section shows you sort of the abnormal strands of the hemoglobin as they sort of stack up inside those red blood cells, causing the shape to change from that nice, soft, squishy donut into sort of a sharp or sickle-celled shaped red blood cell. You can see from this diagram what happens. The red cells get jammed up as they're traveling through the blood vessels, causing blockages that what cause the pain that we typically think of when we think of sickle cell disease. Who does it affect? So here's a little bit about sickle cell disease around the world. It is the most common inherited blood disorder worldwide. It's estimated that up to 40% of people coming from the sub-Saharan African region have the sickle cell trait. We think that there's approximately 300,000 babies born worldwide each year with sickle cell disease. In Canada, we estimate somewhere between 5,000 to 7,000 patients with sickle cell disease are living here in Canada. And just a little addition to that, just Newborn Screening Ontario data from their website talks about sickle cell disease affecting 1 in 400 births in Ontario. And then just to put this into perspective, when we think about inherited diseases, cystic fibrosis is often a disease that we may be familiar with. And cystic fibrosis, also screened by newborn screening, picks up about 1 in 3,600 births. So you can see that sickle cell disease is by far a more common genetic disease that is here right in Ontario as well. So sort of the hallmark and what most people would think of when they think of sickle cell disease is a sickle cell crisis or a pain crisis. It's probably what lots of us will remember from nursing school, learning about what is a pain crisis. Has lots of different names in medical charting. You'll see it written lots of different ways. VOC for vaso-occlusive crisis, VOE, pain crisis, sickle cell crisis, lots of things. It's estimated that adults living with sickle cell disease, they're reporting that they have pain more than half of their days. Manageable at home for the most part, but that's an awful lot of pain, an awful lot of days. Lots of sites, or more common sites, I guess, for sickle cell disease pain crises. Often people will tell me it's lower back, legs, arms, ribs, but it can happen anywhere your blood flows. And typically when they're having a pain crisis, we think of sort of deep bony pain, and it's the little blood vessels going through the bones that are causing that deep pain. Are there triggers for a sickle cell crisis or a pain crisis? There are certainly things that can potentially add to a pain crisis: infection, asthma, extremes of weather, hot or cold. Stress can be added to that list. So triggers, they may sort of cause this pain crisis to happen, but they're not because you have infection, you will get pain. So triggers are things that, we teach patients how to modify or think about. So we, teach them how to dress for the weather and sort of dress in layers, avoid chills, drink a little extra so that they're well hydrated. So if there is some sickling happening, there's sort of lots of fluid also going through those vessels to keep the sickle cells from causing blockages. But this process is happening with or without triggers, and the pain can happen with or without a known trigger. What's happening to cause the pain? There's a few things going on that is causing the actual pain. It's the hypoxia. So you've got a blockage. So there's part of the body being deprived of its regular supply of oxygen. There's some ischemic tissue damage going on, and there's certainly inflammation. You can imagine the scraping of sort of these sharper cells inside the vessels, causing inflammation. Really importantly, what does sickle cell pain look like? This is on the one side of your screen where you see the baby and the swollen, red, sore looking fingers. This is what's called dactylitis, and this is what our young sickle cell patients, this is a presentation of a pain crisis in a wee one whose sort of bones haven't gotten hard yet, so that they're still sort of malleable, and there's probably a blockage inside those little vessels in the little tiny bones of the hands and feet. And because the bones aren't hard, the bones are swelling, we're getting the redness. They'd be hot to touch, they'd be painful to touch, and certainly this baby will be crying and letting us know without a doubt that there is pain happening. This picture is kind of an important picture for, I think, all nurses to keep in mind, especially those working with adult patients with sickle cell. Keep this in the back of your mind when somebody comes and describes pain to you, because sickle cell pain isn't visible once our bones fuse and get hard. So sometimes this is just a good thing to keep in the back of your mind, because there's no question when you look at this that there's something painful going on. On the other side of the slide, you see a picture painted by a patient with sickle cell disease, an artist with sickle cell disease in the US. And this is one of many of the pictures he's drawn to kind of, express to people, the pain of sickle cell disease. How do we manage, or how do you manage pain in the emergency department? Typically, we just exclude any other causes. Somebody comes with sickle cell disease, we're thinking about vaso-occlusion, and most sickle cell patients will be able to identify that this is, my typical sickle cell pain, but we do need to rule out any other causes of pain. Hydration is important. We've got sort of a traffic jam on the highway is what one doctor has described what's happening inside the vessels for sickle cell. So if we can get a little extra fluid in there, it'll reduce the amount of cars that are blocking in the traffic jam. So we do want some hydration, because often dehydration is a bit of a cause. We don't want to overhydrate, but certainly we want to give them hydration. Oxygen can be used, especially if the patient is hypoxic. There are some adult patients who find great relief from the oxygen. So it may not be because of hypoxia, it may just be something that does help them feel better as far as managing their pain. And then pain management is the key. So we want to move quickly to this, a rapid triage, starting with IV opioids. Some patients will kind of know their the opioid that works well for them. And they may even know the dose. We can add other medications along with the opioids to get rid of the pain. So as an ER nurse, quick IV access and quick pain medicine, ideally within 30 minutes is what's suggested from presentation to pain relief. Effective first dose and reevaluating frequently, using pain scales, monitoring respiratory status. And, outside of the initial sort of bolus, we can think about things like incentive spirometry to prevent any secondary problems from sort of maybe the sedating bits, respiratory sedation from any of our narcotics that we use. Typically, we don't use transfusions, blood transfusions, when we're managing a pain crisis, unless there was an acute anemic picture showing, because transfusion doesn't modify the course of pain. It's just something that you can keep in the back of your mind. What are the other complications that I should be aware of with sickle cell disease? This is a fantastic picture, and I hope you can see it on your screens. Sickle cell disease is an inherited problem in your hemoglobin inside your red blood cells, and your red blood cells flow everywhere in your body. So this is a disease that can affect every single organ in your entire body. We often think about the complications of sickle cell disease, and we can put them sort of into two buckets, one being sort of the acute complications and some being the chronic complications. And for lots of us, sort of knowing the acute complications, like the pain crisis we talked about, the blockage in the blood vessel, you can imagine this can happen in the head, causing a stroke, in the chest, causing an acute chest crisis, can happen in the spleen, which would back up all of the blood flow that would normally be going through your spleen, and create a picture of, usually a picture of sort of pallor and increased heart rate, because you can imagine all of your, the whole volume of your blood being sort of trapped inside the spleen. So those are some of the sort of acute things. And one I do just want to point out is also priapism. So, for our young men and even our teenage boys, having a blockage from their sickle cell disease that happens in their penis is painful, and a reason that they would present to emerge, and probably a reason that, is a sensitive reason. So just being aware of that, and what you can do to help manage, perhaps the embarrassment of it, but the reality of this is an acute complication and we need to treat. Do we have treatments for sickle cell disease? We absolutely do. In Canada, we have, in Ontario specifically, we have early identification. Most provinces in Canada have sickle cell added to the newborn screen panel. I don't think we're at 100% across the country, but we're very close. So learning that your child is affected with sickle cell early means that you can be connected to an expert team, receive the education as to what to expect. We start all our young ones on prophylaxis, usually of amoxicillin, and we start them on the path of getting all of their regular childhood immunizations, including some of the immunizations that we typically would give a little bit later in life for some of the bacteria. We start them earlier. We can, when we know somebody has sickle cell, we can do some routine screening. Specifically, we do an ultrasound looking at the blood vessels in the head that can tell us a bit about, are there any blood vessels that are a bit more narrow than they should be, or increased blood flow that can tell us a bit about their risk for stroke, and help guide what we may do as far as how we treat them before a stroke happens. Folic acid, making sure their diet is good, and sometimes supplementing with folic acid. Folic acid is a building block for making red blood cells. And we know in sickle cell disease that these abnormal cells are being broken down and turned over quickly. We have disease modifying therapy that sort of changes how the sickle cells act in the body and the damage they can and can't do. If we use regular red blood cell transfusions, we're kind of diluting the red blood cells in the body so that we're sort of halving the amount of sickle cells that the body makes. We're also suppressing the bone marrow so it doesn't make as much, because if we're giving red blood cells, eventually the bone marrow can kind of quiet down and not have to work so hard because it's got enough good red blood cells in the body. We do this for some patients who have had a stroke. Sometimes we use regular blood transfusions on a chronic transfusion program also for preventing a stroke. Hydroxyurea is the bolded one, and the picture kind of is telling you a little bit about how hydroxyurea works. It's our sort of long-standing disease-modifying therapy that we use. It's a once-a-day oral medication that works to increase fetal hemoglobin, which is, what our bodies make when we're still inside the womb, and fetal hemoglobin does not sickle. So hydroxyurea works to sort of increase the fetal hemoglobin that the bone marrow produces, or turns it back on, and therefore decreasing the sickled hemoglobin that the body makes. And again, when it works well for people, we can increase that fetal hemoglobin in such a way that it's like they have a sickle cell trait and not the disease, and therefore we're protecting their bodies for the long run. There are some new agents, none of which are approved in Canada and may not be approved in Canada. At this point, I think the data from the testing that they've done on these new drugs, all that have come out in the last 3-4 years at the most, none of them have sort of surpassed the results of hydroxyurea, which is very well tolerated for many, many of our patients. There are curative therapies that exist. We can do a matched sibling donor transplant, stem cell transplant. We can do that in Ontario at the Sick Kids in Toronto. And sort of more exciting is clinical trials that are looking at gene therapy. In Calgary, they have worked on doing sort of alternative stem cell donors using haplodonors. So a half match, usually a parent, and have had some success with that as well. But the gene therapy seems like perhaps this may be the way to go, where it's a little bit like a stem cell transplant in lots of ways, but basically engineering the patient's own cells to produce back to producing fetal hemoglobin, and instead of S hemoglobin. So exciting things that are to come, but lots of options nonetheless. And some final thoughts, I guess, to leave you with when thinking about sickle cell disease. There's many final thoughts. These two pictures here, one is also a picture drawn by the same gentleman who depicted the picture of sort of what pain in sickle cell disease is. The other picture here is shared with permission by one of the patients that we have known for a long time in the clinic here at McMaster. And if I think about him and the things he's told me over the years, language is important as people taking care of patients with sickle cell disease. My patient who has sickle cell disease is an important way to talk about a patient, not my patient, my sickler, or the sickler in emerge, or things like that. Just remembering who they are. Another sort of thought about language is, my patient visits the emergency often due to pain crises because of their sickle cell disease, and avoiding language like frequent flyers or narcotic seekers or things like that. So remembering who the person is and what the disease can do, I think are really important. And then I think just sort of some other thoughts. This is a disease that nobody asked for. They're born with it. They've lived with it for a long time, and keeping that in our mind can be helpful when we're advocating for our patients. Pain is what the patient says it is. I have vivid memories of a nursing instructor telling me that, and maybe not understanding that completely until I worked in this population. And it is important. And I think of that picture of the dactylitis, and remembering, we don't see what pain is on the inside. And there's a visual where we can see it. So really listening to the patient and advocating where we can, getting pain medicine in as quickly as we can, using all of the other sort of things at our disposal, warm blankets, warm liquids, a hand to hold, whatever it may be, to help alleviate the suffering when our patients do come looking for help. And then I think the last sort of final thought is and I'm not sure I'm going to capture this in the right way, but just sort of, approaching all of these patients with some awareness. One of the slides when we talked about the worldwide prevalence of sickle cell disease, And that, you know, up to 40% of people living in the sub-Saharan Africa carry this trait. You can also imagine that there's a lot of disease there as well. So, you know, in the past, sickle cell disease was often labeled as a disease of Black persons. And to not dismiss that, but also to just be aware of you know, this disease and where it maybe has fallen in how much attention it's gotten, and just, you know, working to you know, advocate every bit as strongly for all of our patients, regardless of, you know, race, culture, where they come from, anything like that. Yeah, and you know, just remembering, this is a picture of one of our patients, and he's smiling, and a really important thing for him was, you know, you nurses only get to see me when I'm at my worst and feeling my worst and I can't cope, and I sure do wish you'd all get to know me when I'm at my best. Thank you for listening.
Thank you so much, Jennifer, for teaching us about sickle cell disease. Enjoyed this video, please give us a like and a comment. And if you have questions or ideas for future videos, please email pednig.education@gmail.com.